Hey everyone, welcome back to our clinical reasoning series. Today we're going to finish up and move on to part 4, which we've titled Putting It Into Practice. Now, this is by far my favorite video in this entire series. We finally spend the whole time talking about practical ways to put into play all the things that we've kind of set up until this point. Okay? So, as a reminder, like we've done with every video, just a quick review of the roadmap and how we got to part 4. In part 1, we introduce clinical reasoning. We talk about why it's important. And then we spend a couple of episodes in part 2 about how clinicians think, learn, and apply knowledge. And then we had a couple of episodes in part 3 where we discussed different cognitive errors and talked about a couple of techniques to combat them. But then today we're going to spend most of the time talking about other techniques so you can actually improve your clinical reasoning. So if you watch no other video, I would recommend spending some time watching this one, though I would say that the groundwork that we've laid up until this point can give you a lot more context. Okay, but this is my favorite, so let's go ahead and jump on in. These are our objectives today. We want to learn the differences between experienced non-experts and experts. And we're going to learn several techniques that can be deployed to master clinical reasoning. And we're going to appreciate what motivates providers to optimize their clinical reasoning skills. Okay, so we need to remind ourselves that experience alone does not produce expertise. Okay, so for most complex tasks, such as clinical decision making, adults will tend to improve until they perform sufficiently, efficiently, and confidently, at which point they then kind of divert some of their mental energy elsewhere and just start to coast and rely on type 1 thinking nearly entirely. Okay, and as their learning curve flattens, as you can see here, they become an experienced non-expert. Okay? Experts, on the other hand, operate on a totally different trajectory and achieve their own maximum potential because they continuously engage in activities that are designed to improve their performance. So, I want to talk about experienced non-experts versus experts a little bit more. Most of us that are watching this video are probably experienced non-experts, but I want to highlight what in a couple of different domains. I want to highlight things that make experts experts. Okay, so when it comes to things like on-the-job learning, experienced non-experts will only look things up when they need to, and they only consult when they need to. Whereas experts, on the other hand, they're constantly examining their margin of knowledge and the deficits they may have. When it comes to feedback, experienced non-experts tend to focus only on the outcome, whereas experts have developed systematic ways to get feedback, which we'll talk about. And instead of focusing on the outcome, they're focusing on the cognition or the medical decision making that went into that outcome. And they regularly self-audit. In terms of case studies and reading, experienced non-experts will do some occasional reading, and they take a casual approach to solving a case, whereas experts will prioritize reading activity, and they're going to approach each and every case as a simulation exercise. And then lastly, in the domain of skill development, experienced non-experts expect that it will improve. Improvement will come with time. And that's kind of where I was as a resident. I thought, I'm going to see so many patients, there's going to be so much volume that it's inevitable that I'll improve. But that's not always the case. And experts, they take time to deliberately practice until improvement is confirmed. Okay, so let's get into a little bit more. But I think that's a helpful slide in differentiating experienced non-experts from experts. Okay, so I'm sure you're all asking is, how do we become an expert like Dr. Harrison here? And how do we bridge this gap and prevent our performance from plateauing? So I want to start here, and you guys may recognize this slide from part 3, where we kind of introduced these techniques a little bit, and it was done in the context of ways to improve our non-analytic or our subconscious thinking. But I want to dive into it a little bit more. But it's important to remember that improving your non-analytic reasoning is one of the best ways to actually avoid biases and to combat cognitive error. Okay, so let's take a look at this a little bit more. All right, I want to start with progressive problem solving. Okay, so progressive problem solving is intentionally mentally preparing for the unanticipated or the unexpected. Okay, now this can be done either by mapping out contingency scenarios or by creating an algorithmic approach based on the patient's response to treatment. Now, that's quite a mouthful, so let me show you what I mean and how this can help. So say you have a patient with heart failure and you are diuresing them and their urine output is good, their creatinine is improving, their physical exam is improving, their symptoms are getting better. So in that case, we're just going to stay the course, right? But progressive problem solving is thinking through and planning for potentially unanticipated outcomes. Okay, so for example, say that you are diuresing and the urine output is okay, but the creatinine is starting to creep up a little bit. In that case, it's probably okay to stay the course, but we're going to be watching things a little bit more closely. Another unanticipated outcome is that, or another outcome that you could be planning for using progressive problem solving would be to suppose that the urine output drops and the creatinine is rising and the volume status is worsening. Now this is a scenario where you should probably get some help, right? Patient might need a right heart cath. So progressive problem solving is not just continuing diuresis and reacting to unexpected outcomes if they occur. It's where every day you're running through the different clinical scenarios that you might encounter based on the current treatment plan that you've deployed. Does that make sense? Okay, now let's talk about point of care learning. Okay, so point of care learning is taking a purposeful approach to your daily practice and making learning an explicit goal and not an incidental byproduct. Okay, now this not only should be done with your challenging cases, you need to be doing this with your routine cases as well. And like all of these techniques, this does require some deliberate mental steps in order to maximize your illness script development. Okay, so let me show you what I mean. Okay, let's use cellulitis as an example. Some of the literature on adult learning characterizes the learning that professionals do as a list of abilities to be acquired. And as professionals progress, then they kind of gradually check off the items on the list. So for cellulitis, maybe a very simplified version of a list could look like this: knowing how to diagnose it and knowing how to treat it. And as professionals develop efficiency and as their tasks become routine, then they begin the path of becoming an experienced professional or an experienced non-expert. If you know how to do these two things, you know how to manage cellulitis. Okay. Experts, though, on the other hand, they still check off these routine items, but as their job becomes easier and as they gain experience, then they engage in point of care learning by continually putting new challenges on their list. Okay? They seek or even manufacture problems that are slightly more nuanced or more advanced than the ones that they've recently mastered. Okay, so whereas the typical action, the typical cognitive action of an experienced physician who treats uncomplicated cellulitis is to activate their previous knowledge and readily make the diagnosis and prescribe familiar antibiotics. The clinician who is being intentional with point of care learning will still diagnose and treat the same, but they're going to create brief challenges where none existed before. Okay, so they may ask, what are the mimics of cellulitis? Or how might I better teach this subject to my students? Or why am I making the decision to not cover for MRSA? And this additional mental grappling with this seemingly simple case of cellulitis will increase the quality of the exposure, the patient care exposure, and it's going to make a stronger contribution to the provider's illness script for cellulitis. Okay? Now remember our illness script example from an earlier session when we were talking about rheumatoid arthritis. So which of these folks is less likely to make a misdiagnosis? The one whose illness script looks like this, or the one whose illness script looks like this, right? So the clinician with this growth mindset will habitually focus on what is unknown rather than what is familiar to them on a given patient encounter. Okay? Now, I know what you're saying, and that is, I don't have time to go through this mental exercise for every patient that I see. And you're right, but here's the key, you don't have to. Okay, so I recommend just doing this for a fraction of the cases each day, or maybe just pick one patient per day to actively engage in point of care learning. And as mentioned, this approach will revise and improve your illness scripts, which is going to increase the likelihood that this knowledge can be accessed through non-analytical channels, i.e. your subconscious reasoning. Okay? And you can access that information in future patient encounters, which is especially helpful when patients present with atypical presentation. So the whole point in all of this that we're talking about is to improve your illness scripts and to improve your non-analytical reasoning, which is going to reduce diagnostic error and make it more likely that you're going to arrive at the correct diagnosis. Okay, the next technique, seeking systemic feedback. So let's start here. How many decisions do we providers make every day? Dozens, hundreds, maybe more. And making decisions is one of the biggest parts of our job, right? And for me, it's what makes going home after work and being asked what's for dinner maddening. Okay, so I can't make another decision, right? Our decision fatigue is real, and I think physicians and APPs really suffer from this a lot. But even though we make all of these decisions, we often have very limited opportunities to link our decisions to results. Okay, so within the context of clinical reasoning, let me phrase it this way. We have very limited opportunities to link diagnostic and management judgments with actual patient outcomes. Now, there are a couple of reasons for this, right? So our work patterns with how our service manages patients contribute to this. Very rarely, if you admit the patient, are you going to be the physician who cares for them for the remaining part of the hospitalization, right? We're all super busy, and our time spent with patients is limited, and the healthcare system is really fragmented. Okay? But despite these challenges, we have to recognize that when feedback is curtailed, multiple opportunities for learning and optimization are forfeited. So, and the human tendency is to equate the absence of feedback with positive feedback. In other words, we tend to think that no news is good news, right? But that's not the case. Okay, and believing in this will lead to a distorted and inflated self-assessment. You're going to think that you're more accurate than you really are. Okay? Now, there are plenty of examples where this "no news is good news" adage is a fallacy. Consider the patient with seemingly benign chest pain that you sent home with a PPI who represented at Grandview with a dissection, and you never knew about it. Or the young man with what seems to be mechanical back pain, and he's got no obvious red flags, and so we discharge him home, but he comes back to the ER a week later and gets admitted to neurology service for cauda equina due to a malignant spinal tumor. And since they don't come to our service, you never know about it, right? And in both of these situations, you may have had perfectly reasonable decision-making encounters with each patient. But if you're not able to methodically examine your own performance, you're not going to capture as much wisdom as you otherwise could. Okay, so the point that I'm getting at is order to improve, you have to see the outcome of your decisions. So how do we do this, right? How do you ensure that you see the outcomes of your decisions? Okay, I've already talked about the obstacles, so I have a few thoughts on ways that you can intentionally do this. So there's a couple of different things that you can do. But first of all, clinicians must develop their own system. Okay, so for me, I personally tend to focus heavily on transition points for patients, meaning the point at which they no longer belong to me for whatever reason. Okay, and then I'll keep a separate patient list in Power Chart, and I go back and follow up on them in some capacity. I think this is really important for admissions when the patients present undifferentiated. Of course, with how our service is organized, after you admit a patient, you probably won't care for them the next day, right? So say you're on a swing shift and you've admitted a patient with shortness of breath, but you're not quite sure of the etiology, so you just order some symptomatic treatment along with a basic workup, and you get them tucked in for the night. Now, what I recommend is that you follow up on that patient within the next couple of days. See what the actual diagnosis was. See how they're progressing. That way, you are able then to attach their presentation at the time of admission with an actual diagnosis and an outcome. Okay. I also think doing this when you switch off a service is incredibly important. So many things will come to light when a fresh set of eyes takes a look at the chart. I do this when a patient decompensates and goes to the MICU or the CCU. And I even do this when patients go to the palliative care unit. I find it especially helpful to see how long patients live. Do they die in-house or do they make it home? This helps me figure out how accurate my prognosis was, and I can then further modify future goals of care discussions based on the feedback that I've given myself. Lastly, I do this for discharges. Has my patient that I've been a little bit worried about been readmitted? How do things look when patients see their PCP in a couple of weeks? Did I totally miss the medication on the med rec? That sort of thing. But again, what this is doing is building up your clinical repository, it's refining your illness scripts, and it's enhancing your non-analytic reasoning, all of which, again, the goal is to improve your diagnostic accuracy. Now, our group also needs to foster this culture, and I mean this from two different angles. One, groups need to have formal settings for feedback, just like we do with our clinical improvement conferences or something along the lines of M&M conferences or annual evaluations, but also individually, meaning when you come onto service and you catch something that is missed, you need to give your colleagues some feedback. Now these, of course, can be big things, right? But even something like, hey, you documented no focal deficits in this patient who is a quadriplegic. Okay, we need feedback on these little things so that we can improve in the future. Okay, a key point here though is that outcomes must be analyzed systematically and without overreaction or minimalization. Okay, you cannot make a wholesale change in your practice patterns based on the account of a single event. Okay, so let me say it this way. You cannot let single events of the past influence probability assessments in the future. Okay, so if you do, you'll end up getting a CT angio on every patient that comes in with the sniffles, just in case. You miss one PTE and then it totally wrecks your evaluation of every patient who's short of breath for the rest of your career. Okay, so instead of doing that, as we talked about earlier, it's much more important to actually focus on the cognitive error that led to the outcome, not the outcome itself. All right, simulation. So what's the common link for all of these folks here, right? So athletes, musicians, soldiers, pilots, chess masters, they all spend so much more time in simulation or in practice or in film review than they do in actual competition or actual flights or actual military campaigns, right? And this type of approach ensures that they are as prepared as they possibly can be for when it really matters. Take Tom Brady, for example, considered by many to be the best quarterback ever, spends dozens of hours every week watching film, despite the fact that he's seen, every defense known to man. He watches as much film as anybody, okay? Now, physicians don't seem to do this as much, but our stakes are just as high, right? Now, we do have a lot of practice, so to speak, leading up to attendinghood and throughout residency, but we don't really make use of it as much as we probably should afterwards, especially once we kind of get set into our careers. And the reason it's important then is because it's only then that we actually have the experience and the clinical context to really appreciate what goes into some of these cognitive errors. Right? So when it comes to simulation, the field of medicine has really embraced it when it comes to motor skills like laparoscopic or robotic surgery. And it's great for team dynamics with things like ACLS. But the field has really kind of yet to embrace simulation for cognitive challenges that really define our most common procedure, which is making a diagnosis. Okay, so I do think that we will see the use of SimLab continue to expand in the future, especially for trainees. But beyond SimLab, which is harder for us to do, I think there are some excellent online resources that we can use to simulate cases that can be really helpful in practical ways to exercise your clinical reasoning muscles. And virtually every major journal puts out these types of resources. My personal favorite is probably the cases in the Cleveland Clinic Journal. But all of these online simulations are really good. I can send out some direct links if anybody has trouble finding it. But make use of case vignettes and published cases and image quizzes that these publications put out every month. Now, like I keep saying, of course this takes effort and you have to make time for it, but being intentional about simulating cases can really positively affect outcomes. And like I've said for all these techniques, the goal of simulation is to build and strengthen your repository of illness scripts. Because we all know that in the real world, undifferentiated patients don't declare the key elements of their case, right? Okay. Let's talk about deliberate practice. Now, many of us kind of do this without actually using the term, but I want to break it down and kind of give some examples. So, deliberate practice is defining a high-value skill that lies beyond your level of competence, and then focusing concentration and practice explicitly on that specific task, and then integrating feedback to close that gap between current and goal performance. In other words, find an area where you have a deficiency, focus on it intentionally, and then build in feedback mechanisms to help close the gap within your deficiency. Right, now, let me give an example to show you what I mean. So, say you're examining a patient and you notice a murmur on exam. And based off your exam, you're going to make a presumed diagnosis, but you order the echo. Then you're going to follow up on the echo results. And then here's the key part. This is where learning really takes place. You have to close the loop. So once you have the official results, then go back and auscultate again with the confirmed diagnosis in mind. We also do this frequently with chest x-rays. You order the chest x-ray, you make a preliminary read on your own, then you follow up on the official read. But then again, the key part is taking that official read and connecting it to the review of the film a second time. Okay, so let's kind of start wrapping up here. As a reminder, this is the gap that we're trying to close. And nothing in medicine is higher stakes than effective and accurate clinical reasoning. And I think that we can all appreciate that continuous professional development demands time, it demands effort, and it requires time and effort beyond what's required for actual patient care on a day-to-day basis. But outside of medicine, I think we'd all agree that no progression of skills or improvement in performance is going to occur without devoting extra time and effort to that skill set. And there's no reason to believe that clinical reasoning is any exception to that rule. Now, all of this extra effort takes some motivation to get better, right? Unless you're being forced to do it. There's got to be something else that motivates you. And I think motivation can be different for individual clinicians. Some have a desire to master one's field. Some enjoy learning. Others, it brings them job satisfaction. For a lot of us, it allows us to be better teachers. At the core of it, I think the important part is that you should get better patient outcomes. And then I would argue that there's also a moral and ethical duty to constantly work on improving your diagnostic skills. Now, all of those kind of resonate with me to some degree, but I think the Mamba mentality really kind of resonates the most. And basketball fans who are listening are probably familiar with this, but this was Kobe Bryant's approach to life, and I think it's a great mantra, especially for growing clinicians, and that is to be on a constant quest to be the best version of oneself. And I think that can motivate a lot of us to put in the extra time, put in the extra effort to improve your clinical reasoning skills. And if you're not careful, you'll end up becoming an expert if you do. All right, that's all I got. I appreciate everybody watching these videos. If you have any questions, please reach out. All right, thanks.